a role that's prevalent over here. So we do lots of things that many of you already do. We just have that assigned to us. So I'm going to talk a little bit about how we in the PFT lab at Michigan Medicine support our CF patients. So we support them in 3 different ways. We perform all the PFTs for our patients, both inpatient and outpatient. We do extensive education, and that's how the primary reason we support ongoing care with CF. But we are also in charge of doing all the sweat testing at our institution. So we are instrumental in diagnosis if there's a follow-up sweat that's needed for CF, but we do all the sweat testing. So pulmonary function tests, predominantly our CF patients get spirometry done. We start them at age 6. We may introduce it at age 5, just to get them used to doing it. It's a very technique and effort-dependent procedure we want them to do, so it requires a lot of time and coaching. So basically, spirometry measures the amount of volume and the speed or flow of air that can be inhaled and exhaled. Proper technique is key to getting good results. We spend a lot of time with our patients going over this, especially at a young age. It's just repetition and practice. The first thing that we really work with on them is just getting them to be not anxious with the spirometer. So it may take many months or a year before they're actually giving us reliable data, but we spend a lot of time and we break it down into some basic steps. So we want them sitting up straight. So sitting up or standing. Good seal on the mouthpiece is important so there's no leaking. That's often the hardest part for them, having them not put their tongue in the filter. It's like a toy, right? And so you have to kind of teach them how to do it right. And then just getting them to breathe in and out. And so that we start with all that, then we get them to take a big breath in and blast it out. And as soon as they blast it out, they want to come off the spirometer, and then we have to work at that. So then we keep blowing, we get them to blow longer, and then of course we add in at the end, we can get a big breath. We do this by using a lot of animation with our younger patients. It helps them to focus on blowing hard and long. After we get some efforts, the team does an assessment of the effort to figure out what do we need to focus on with our next effort. Was it not a big enough breath? Was it not a hard, fast blow? Did they just not blow long enough? So we assess the loops and then we repeat. As I mentioned, we introduce it at age 5, often with just a spirometer and getting them to blow on it. We send it home with them. We may get them to go in with the equipment, but really it's just to get them used to it. Being comfortable with the technique is important, not only for the patient, but for the parents and caregivers as well. We do test everyone 6 and above in clinic unless they are completely unable to physically perform the test. And then we review the test immediately. We have the ability to see trends, so we can see all the previous tests. So our staff does a quick peek before clinic to kind of see where in the last year, where was their high mark, so that we know if they're 10% below that high mark, then we're going to institute our bronchodilator protocol. So we kind of have an idea of what we're looking for before we test the patient. And so, like I mentioned, we have a protocol we instituted as part of our E.U.P QI project that if they drop below 10% from their highest mark in the last year, we are automatically tasked with giving them a bronchodilator. So we would traditionally give them 4 puffs of albuterol, unless they have a reason to not have albuterol and Xopenex is specified in their chart. We give them the albuterol, we wait our 15 minutes, and then we repeat the spirometry to see if there's any reactivity. Tips for success. This is it's effort dependent, so coaching is huge. I have a great staff that works well with the patients, and so it's really, they do an amazing job of getting someone to perform. We encourage families to voice what's worked well in the past when doing spirometry. have a team of 6 RTs, so they might not always have the same RT when they come to clinic, and so they may have a favorite, they may know a trick, maybe there was a connection that was made, so we encourage a lot of communication. We want this to be a good experience for them. We want to reduce anxiety. A lot of our patients, we see them first. We see them first when they come to clinic. So we already can look at their weight when we go into our system. We can tell if their weight is up or down. If it's down, that's already a red flag for us, like maybe there's something going on. And then they're anxious. They know that those numbers can determine the course of a hospital admission or being able to go home. And so a lot of them get anxious about their spirometry. And so we try to reduce that. A lot of times the parents are anxious, so if we have the ability to take the patient without the parent and allow another discipline like our dietitians to spend time talking to the parents while we do the testing, we can try to optimize the visit that way. And then we also talk amongst ourselves on the team to find out who maybe is at increased risk for extra anxiety, who maybe needs to modify our workflow a little bit because they're super anxious about things going on in clinic visits. So as a team, we huddle, we talk about that every week before clinic starts, and we kind of make a plan if we need to adjust. And then we always are taking advantage of the teachable moments. Every interaction with our patients is an opportunity to teach them something, reinforce something, and help them to participate in their care. And we take the opportunity to educate the children. At the beginning of the CF diagnosis, it's the parents that are responsible and need the information, but as they grow and get older, it's important for the children, the younger patients as they grow, to understand why they're doing the things they're doing. Chris's team and my team work very closely together on that level. We want the patients to participate. Understanding why they're doing something and why that's important helps them to know that even when they don't want to do it, there's a reason we're asking them to. Special considerations for pediatric patients. They are not just little adults. They really are not. They have their own mindset, and they're children first and foremost. So it's all their ability to perform spirometry and give us really adequate results is dependent on their developmental age, their personality, and their interests. You know, you can have a 4-year-old that's ready and marches right up and like gives you an amazing thing, and then you can have a 16-year-old that you just have to work really hard to produce something for you. So you really just have to know your patient and tailor your approach to that person. The environment should be calm and relaxed with good coaching. This is where sometimes when there's parents in the room and the parents are anxious, the patients pick up on that. They know that their parents are really anxious about these results, and it causes them to fidget more and pay attention less. So sometimes we have to have them be calm and sit down and say that, you know, just one person giving instructions is really be helpful right now. Sometimes you have to get creative. It doesn't take long because we see our patients every 3 months to develop really relationships with them and understand a little bit about them. So you get creative, you learn something about that, you make that connection, and then you bring that to your clinic and to your testing and your interactions with them. Using incentives, most of the PFT programs have incentives on there. The kids love it. I mean, I've used it on teenagers. So it just depends on what they need. And they'll tell you, I want to do the balloon one, or I want to do the flying toaster one. And okay, you're already engaged and ready to like help perform. So those are great things that we can utilize. Just being patient. We want to make sure it's a positive experience. Everything that they do right, we want to give positive feedback for. So if we don't get results, we're just like, it's okay, you'll get it the next time, you know. And we just go through that, and we want them to be not afraid when they come in to do it. And so it takes time, and they're all different. We spend a lot of time doing education with our patients. We review the order of inhaled therapies with our patients. We include proper techniques for using with the MDI and spacer. If they're using a nebulizer and they have questions about that, we go over that. We review huff coughing, we review airway clearance. We're more device focused in the RT realm, and Chris handles all the other part of airway clearance, but we do cross cover each other a little bit there. We review approved cleaning and disinfection of equipment, which is super important in CF. And then we also provide, like to do, an annual assessment where we sit down with the patient over about 45 minutes and we kind of review all this stuff. What equipment do you have? What size vest are you using? What's your program? Is it working? We ask them to bring the equipment in and we go through it with them. Does it inflate properly? Does it look like it's the right setting? So we take a lot of time, and that's what we try to focus on when we're doing our education. So we review our order of inhaled medications. We always ask, what do you take first? They might not know the name. Maybe they're identifying the color of the inhaler. And so we can kind of figure that out. Why do you take that? Well, it makes me breathe better. We just try to get them to engage. And hopefully by the time that they're 8 or 9, they're able to answer these questions for us. And we kind of ask the parents to let them to sit back. You should know. I know you know. Let me see if Johnny knows. So this is what we go. We go through the medications and why they're taking them. We get to Pulmozyme. We focus on, are you keeping it in the fridge? Because that's an important part of storing that medication. We talk about after that doing your airway clearance, which they can do through the first 3, and then we want them to do their huff cough and their coughing before they would take their inhaled antibiotics and steroids if they needed to, because those need to go into our cleaned out lungs so they can sit and do their work. We review proper MDI technique with spacer. We ask them to bring it in. If they don't bring it in, if they forget their equipment, we just pretend. Just show me what you're gonna do. And you shake it up, pretend to put it in your mouth, and walk through the test. Demonstrating it is the best way, just as Chris mentioned earlier, because they'll tell you, oh yeah, I know how to do that. We wanna watch them do it. So that's what we do with that. Nebulized medications, again, we want to reinforce good techniques with that, sitting upright. If they're using a mouthpiece, making sure they're staying on the mouthpiece during the treatment. Kids will like to curl over on their side in their bed, turn it sideways, have it hanging out of their mouth halfway. We don't really know what they're getting when they're doing that way, so sitting up, making sure you're breathing in the medication, reviewing how long a nebulized treatment should take on a home compressor. That gives us feedback on whether the compressor is functioning properly or not. And then, how they should go about that. If they have questions about their compressor or their nebulizer cups, then we can answer that and help them with that. We go through airway clearance device techniques. So most of our patients have aerobicas, and so we'll review that technique with them. And we always want to stress that although you may have an aerobica and you may have a vest, you really need to have something that's a backup. So when they're younger, we want to make sure that the parents are still comfortable being able to do P and PD with their patients. If they say that they don't remember, then that would be a sign for us to refer to PT for a review session so that they can make sure they have their skills. Electricity goes out, you can't use your vest. You're traveling a lot, you need to know that you can use your aerobica. So there's always a backup to airway clearance. It's not just one thing. We review huff cough technique. Super important, start that as young as possible. I was happy to hear today that we talked about it yesterday and someone tried in clinic. It's a process like anything else. These are all effort-dependent things we're asking our patients to do, and so we have to make them want to make that effort in some way. basically we get them again to demonstrate proper technique for us, and it may take some time, but I mentioned this yesterday to the group, is a great training tool for the younger kids is to take a piece of large bore aerosol tubing. It's about the right diameter to keep the glottis open in the mouth, and you cut a couple inches off of that, and they can keep that in their mouth, and they can practice the huff through that, and it gives them that feeling. Instead of using their throat, it gives them the feeling of using their abdominal muscles. So there's little things that you can do like that help them learn the right technique. If they're telling you that it hurts when they do their huff coughing, they're not doing it right. It shouldn't hurt. We spend a lot of time making sure our patients are cleaning their equipment properly. There's multitudes of ways that they can clean their equipment. If our patients have Pari neb cups, they can boil those, which is a super easy way to clean equipment. If not, there's cold methods that can be used with isopropyl alcohol and or hydrogen peroxide. The important amount to know with that is that, you're soaking for the right amount of time. So we have 5-minute soak with the isopropyl alcohol or 30-minute soak with hydrogen peroxide, but then it's really important that it's being rinsed with sterile water. So they can just boil some water, keep a small amount, enough for a day or two of rinsing in a container that will be free from getting contaminants. And they can use that to do the rinsing, making sure everything is perfectly dry before reassembling or storing somewhere. In our annual assessment, we try to get our patients to come in yearly up to the age of 10. And then after that, we found there's a little bit of resistance to having to bring their stuff in all the time. So we went to every other year. And then as needed for the older group. We have the ability, one good thing from the pandemic was virtual care. So we have the ability that we could conduct these virtually with our patients. So they don't actually have to bring anything into the hospital anymore. We can see them doing it in their own home environment, which makes it even more comfortable for them. So they're not bringing it, again, we review the medications, we demonstrate, have them demonstrate techniques. If they say something's not working, we can help them with replacement equipment needs. And then we always encourage participation of the patient. So in summary, the respiratory therapist has the opportunity to interact regularly with CF patients in both the outpatient and inpatient setting. It's a great opportunity to see them at their best and maybe at their worst, so we can really develop a good relationship with them. Every interaction is an opportunity to build a positive relationship, reinforce and educate patients and families, and then sharing the information with the care team is vital to a multidisciplinary approach. Anything we learn, they share anything with us, while they're doing spirometry about how they're feeling or not, that immediately goes into the team room, to the provider, the social worker, somebody else to communicate, hey, we heard this, maybe you guys should know about this, because maybe there's something else going on. So we are happy to be on the team, and we love to support our CF patients. And that's just a couple pictures of some of my staff doing some spirometry. Thank you.
Thank you, Sharyn, for the explanation of the role of physiotherapy and how to prepare pulmonary function in fibrosis patients. I know we